friend of 30 years who lives in Manhattan, and it was his 77th birthday today, and I sang him happy birthday and heard all about Manhattan and coronavirus and quarantine and all that sort of stuff. He's maintaining his practice on FaceTime, which I think is a little dicey in terms of confidentiality, but there you go. And anyway, giving him a little pep talk because he said it's pretty freaky in Manhattan right now with all the deaths and illness. So it's 9 o'clock Pacific time. Let's jump into it. I'm going to switch and screen share to the slides. And okay, wait a sec. I have to find the slides. See if this will do it for me. I think this might. For this first part today, we're not going to need much of the slides, but I'll get into that in a moment. Let's see. Okay, there we go. And let me see if I can pull this off. Aidan, I may need your help in this.
Hi, Doctor. How can I help?
Hey, how are you, Aidan?
Good.
Let's see. Okay. There we go. Okay, good. You can see what I can see. I think I'm going to go to knock off my video and we'll concentrate. And I also have to bring up the chat room. Chat. Okay, there we go. Good enough. Hey, excellent. There's something from Jason about HIPAA. All right, I'm going to leave Jaros alone. Sounds like good advice. And Jason, in case anyone needs, Doxy.me is a free-to-use HIPAA-compliant web-based application for teletherapy. Also, it is easy to use for therapists and patients who are not as tech-savvy. That's great. Excellent. Good. Good, good, good. Okay, I'm going to move that to the side of my screen anyway. And we will carry on. Now, we're about at slide 62. Let's see if I can get through that quickly, down to 62. And we're going to talk about charting today, or at least this morning. Okay, some good things back and forth about telemedicine. And let's go to the slideshow. Okay, great. All right. I think I'm oriented. How's everybody else? Should we get going? Sure. So today we are going to have our second half of the course, which is quite a bit different from the first half of the course. First half of the course was on regulatory issues related to psychopharmacology, ethics, guild professional guilds, ethical standards, which nicely you can see are pretty much all the same in the sense of do good, do no harm, be honest, be trustworthy, and be fair. To me, that's what it sort of all boils down to, with a lot of nuances intermixed in that. There's a lot of pressures to not be fair, to not be judicious, to perhaps not even be honest, etc., with influences from many different sides, including the business world, the pharmaceutical industry, who would like to have you use their product to make a higher profit, regardless of what that product is in some ways. And a lot of people with their own biases, including our own, that could get in the way of fairness, honesty, and good science. So just be aware of the shark-infested waters that you run in when you are involved in prescribing of psychopharmacology, the various stakeholders that are often in opposition with each other, and you cannot satisfy all of them, nor should you try. And keep your wits about you and talk with colleagues, get a sidewalk, hallway consults, opinions, etc. And try to do the right thing. Learn from your mistakes, be humble, and keep moving. And frequent follow-ups and checks. All right. For this section of the course, the morning section here, I'm going to refer to the reference material, section 3. And I ask that you pull that up. It's not a tremendously long section. I think there are about 20 or 30 pages to it. And it's going to help us orient towards getting through this material. I'm also going to do a whiteboard. With some nomenclature and stuff that I'm going to write out in handwriting for you, that has to do with medical charts and records, etc., and prescriptions. When that happens, we'll switch over to a whiteboard from this slide. In this section, I'm going to talk about these different bullet pointed topics. We'll go over them in some detail so that you're all on the same page as I am. And we'll have a level playing field, if you will. Okay. I've said this many a time, but I'll keep repeating myself. If it isn't documented in a court of law, it's considered not to have happened. You cannot defend something that is not documented by saying, I forgot to document it, or I meant to document it, or it wasn't necessary to document it. In a court of law, the jury of your peers and the judge will conclude that you didn't do the job, that you didn't do the assessment, and that will find you at fault in medical malpractice. It's really quite that simple. You can make mistakes, You can make clinical errors in judgment. So section 3 of the reference material, should we jump off and get the reference material? Rebecca. I guess so. I'm not sure what you mean by jump off. Does that mean that you go away from the slides? Sure. Yeah, go away from the slides because we're not going to, that's really less important, but not quite yet. Hang on just one sec. What I'd like to do is spend a few minutes before you do that, and then we can jump off, so to speak, and go to the reference material. Another thing I'll mention, and this is obvious, but it needs to be mentioned, that people need to, if you're not doing electronic medical records, and the next slide is on electronic medical records, and I'll go through that before we go into the reference material. Oh, okay, Rebecca says, get off of Zoom because I don't know how to do it without leaving the meeting and then coming back. I get that, Rebecca, and maybe Aiden has some advice for us all. But if you get off Zoom, doesn't that mean that you lose me too? And all you're with is the reference material. I'm confused. And Aiden, maybe you could clarify that. Just minimize it and get to Moodle, says Carmen. Okay. Toggle between the two. Log on from another device. Oh, okay. All right. Folks, I hope this works.
Thanks for everyone. I was about to just message privately to Rebecca, but everybody helped publicly. I appreciate it.
Great. Okay, so we have a solution for that. All right, thank you, Aiden. Good handwriting, if they can't read it, they're not going to read it, and it's in the category of you didn't document it, it didn't happen. So you're at fault if you have bad handwriting. If you have bad handwriting, it's your job to write in a way that can be read. So, for example, my internist of 30 years in San Francisco had a benign hand tremor, and his handwriting was atrocious, and he literally wrote half-inch high letters in non-cursive in block letters in order to be able to his notes to be read. So he would, and he'd have spaces between so that you could definitely read his writing and understand it, but it was about 4 times larger than normal writing. In your notes, always be sure to print your name and sign your name. Put your professional license and date and time the note. Okay? All right. Before we get to the physical chart, I'd like to go through this slide, the next slide, 66, on electronic medical records. As I mentioned, I think it was, actually it was 2010, but it went into effect approximately 2000, or adopted in 2014, was the standards rule to push hospitals and health professionals across the country to adopt electronic health records starting in 2014. They incentivize this by offering higher reimbursements in a modest way for Medicare and Medicaid funded patients. It is increasingly becoming the standard to do electronic medical records and not paper records. So take a look at this slide of what is involved in electronic medical records, slide number 66. Each section, each bullet point represents a section of the virtual chart in the EMR, electronic medical record, that has a tab system on the top of the screen, and you click on the tab, and down falls the record in that within that tab. So these tabs include everything that's here, including a pre-screening for initial problem. When the patient or client calls in, they start an electronic medical record at that point, for the most part. And then there is a tab for the intake assessment, the nursing assessment, the history and physical assessment, the biopsychosocial assessment, the psychiatric evaluation, et cetera, et cetera, et cetera, et cetera. In all the areas that a paper chart had, it's just organized in this manner. Okay, I won't spend too much more time with electronic medical records. I will say that I have attempted to get some sample or blank electronic medical records. I've had a tough time doing that because it's all proprietary and nobody wants to share their product for fear that you're going to steal it from them, and there'll be copyright issues. So I gathered all this material just in a Google search for all the details about electronic medical records. Let me see if there's anything else I want to say about this. No, I think I covered it. And I think that's fine. All right. Okay, let's shift to the references. And I'm going to go back a slide to medical chart documentation standards. And we're going to go through section 3 in your references. You'll see that there are more details in section 3, the first page, 3.1.1. This is taken from one of the more common, popular behavioral health electronic medical record system by Best Notes. They were one of the first out of the gate in approximately 2008 or 7, something like that. And they've refined their product. It's considered one of the best around. Headquartered somewhere in the West. I thought it was Salt Lake City, but I think it may not be anymore. There are numerous vendors. And you'll see there some of the details in this 3-page, I think it is. Yeah, 3-page part of the references of what is involved. They also do some pretty cool things in terms of CRM, which has to do with tracking phone calls, setting up reminders to follow up. People call up, making inquiries, and they are tracked through through the CRM system. And then they go into detail about what is involved in their admissions, the calendar, documentation and standards with that. All the details about documentation, which is stuff that I pulled onto my slide from their material. You have a patient portal, what the patient can look at. And I'm just, okay. Yeah, Jason's point, the psychiatrist where I work can't read his own notes at this point. It's sometimes funny, sometimes frustrating. And that is a big issue, of course. You can have employee messaging within the system. All the medications are tracked. The medication activity reports are tracked. The prescribing is done as a sub-vendor system. Outcome tracking. Afterwards, it's a way to bill and to get codes for billing and making reports. All right. So let's head to this medical chart. This is a phony chart that I put together and hypothetical patient starting on reference page 3.2.1. And this is our patient, John Doe. And John Doe, in a nutshell, attempted suicide by drowning at the beach or attempting to, and brought into a crisis unit on a legal hold. So we're going to cover all of the chart related to John Doe, his hospitalization against his will, the legal holds that will bring us to the next topic after decision trees and clinical algorithms, which is patients' right to refuse treatment, et cetera, and the legal underpinnings for that. So take a look at the 72-hour detention for evaluation and treatment in California. This is called a 5150. It's Welfare and Institutions Code 5150. And it calls for a 72-hour hospitalization forced against one's will for a danger to self or others or gravely disabled. So let's go through the sheet. So Peter Chan is the nurse at the hospital who, at County Memorial Hospital, who is evaluating John Doe. And he writes in the middle of the page, how was he called to your attention? 911 call by a tourist saying a man was attempting suicide by drowning at the beach. Brought in by police to mental health crisis unit. This case is a pretty obvious one in the San Francisco area. A number of people who are so inclined will make suicide attempts by drowning at the beach or jumping off the Golden Gate Bridge. A number of people travel internationally to San Francisco in order to jump off the Golden Gate Bridge as a suicide. It's a tragedy. I can't remember the figures off the top of my head now, but it's something like 200 people a year. And this is why San Francisco has finally raised enough money, I think somewhere like $20 million. and to build a barrier, which is a steel netting, web netting under the Golden Gate Bridge, so that if you jump, you fall about 20 feet into the netting and have less chance of dying. So Jason says, I've often wondered outside of California, do people call someone being psychiatrically held getting 5150'd? It's very state dependent. So in Florida, it's the Baker Act. That's a 5-day hold. It's chapter 51 in Wisconsin, says Heather. So each state has it different, and you would not say outside of California 5150 because it doesn't make sense. It's whatever the state statute is, and each state has its own way of talking about it. Please allow me to apologize for being California centric, as that's where this course originates from, but each state has its own code words for that. All right. And then this form requires one to state how you believe, how Nurse Chan believes that John Doe is a danger to himself, others, or gravely disabled. And you want to use the quotes, preferably. So you get it right from Mr. Doe, the patient's mouth. He stated, quote, "I went to the beach to drown myself. I wish the police had not stopped me." Very important, if you can, to give direct quotes. These quotes are useful in court proceedings. You want to use the patient's own words. So I'm just reading Danielle's point. During the pandemic now in California, with no judges, the folks in Psych Emergency Services, PES, determine if the patient needs to stay without a legal hold, and the client has little to say about it. That's very interesting. Well, let me just make a little nuanced point about that. Judges don't get involved in the initial hold, and we'll talk about this in some detail today. Every state has an initial hold that can be made by a mental health professional, including, nurses, psychiatric nurses, etc., in psychiatric emergency settings, that is independent of any other ruling. So you cannot challenge a initial hold. Not many, but a number of parents have approached me with their adolescent child being hospitalized. After I started taking care of them, they're transferred from the psych emergency department of the local county hospital to me at my hospital on a legal hold. And the parents say, "I want you to break the hold, and I'm going to go to court to get you to break the hold. This is all a big mistake." And what I've always said to them, I've been quite conservative about that. I said, this is what I know about your child that brought them in to me on a legal hold, that they made this attempt or made this statement and or attempt, etc., to harm themselves or harm someone else, or gravely disabled. I don't know your child well enough to have faith that I can break the hold, which I can do. The doctor, can break it. The hospital can break it, but a judge can't break it. It's never brought before a judge. And what I've always said to these parents is, give me the benefit of the doubt, give your child the benefit of the doubt, and leave the hold alone, and we'll assess them over the 3 days. God forbid that we made a mistake and acted injudiciously, released them, and then they did the deed that they were brought in for. And it infuriates parents at times, but it also is a safety valve, or a safety net, if you will. And so I have always made it a practice never to break a hold unless it was my patient. I knew them well. It was a repeat admission. I was confident. I also checked with other staff and got their input who knew the patient. We'd have a little confab of whether or not we needed to break, whether or not we were willing to break the hold. Yeah, and psych techs can write a hold. So you have to be certified by the state in order to do that, right? You have to be certified to be able to put people on mental health holds. Can't just be anybody. When the police brought in Mr. Doe, they put him on a hold. Officer O'Malley, at the top, you can see that. He put him on a hold, but it's the nurse's job at psych emergency to uphold that hold or continue that hold. And then it's the doctor at the hospital who also upholds that hold and continues that hold. Now the time is ticking, right? You don't start from that point. You start from the very beginning of when he was brought in for the 72-hour time limit. Okay. Moving on. Page 2, 3.2.2 is the advisement to the patient. This is a sheet of paper that's handed to Mr. Doe, the patient, that pretty much clarifies what's going on. My name is Peter Chan, RN. My position here is a mental health nurse. You're being placed in the psychiatric facility because it's the opinion of the professional staff as a result of a mental disorder, you are likely to harm yourself. That box is checked. We feel this is true because you stated that you went to the beach to drown yourself and state that you continue to feel suicidal. This is not any secret. This is totally transparent. It began at the moment it was put on the hold, and it continues for 3 days to 72 hours. All right, and handed to the patient. Okay. Now, moving along. Mr. Doe is in the hospital on his 5150 72-hour hold in California. Near the end of that hold, he either has to be signed in voluntarily, he has to be released, or he has to be put on a continued mental health hold. And since Mr. Doe says that he continues to state the wish to die, he's put on a further hold. In this case, in California, it's called a 5250 or a 14-day hold. Every state has a secondary hold. Every state I'm aware of has a secondary hold ability for someone who's still dangerous to themselves or others after the initial hold runs out. So this is the notice of certification that is filled out for the second hold. It's circled that he's a danger to himself or herself. What's the basis of that opinion? He states that he continues the wish to die. What are we going to do about it? We're going to continue 24-hour psychiatric hospitalization. It begins 3 days after the initial hold runs out. In Florida with the Baker Act, it's 5 days after the initial hold runs out. And a copy of this has been delivered to the patient by Dr. Smith. Mr. Doe objected, so that means he automatically requests a review, even if he's not aware of it. He gets a review unless he accepts it and does not object. But he objected because he wants to die. He doesn't want to be in the hospital. So the next page is, the top is filled out. And he goes, Mr. Doe goes before a court commissioner, a judge in California. They send retired judges or retired court clerks that are well-trained and experienced and certified into hospitals to run what are called probable cause hearings in California. And as part of that, this is the legal forum for Mr. Doe to present his case and the hospital to present their case of why the hospital, the doctor, the nurses think that he should continue and in the hospital against his will, and that he continues to be a danger to himself in this case. So the case manager is there, Jerry Dowell, I called him, a social worker. The doctor also is part of this hearing. It's very important clinically and therapeutically for the hospital staff to do this in a friendly, respectful, non-punitive way that is therapeutic. So you do it in a very straightforward, transparent way. The court commissioner, which is in this case B. Brown, writes that the patient states he wishes he had been successful in his suicide attempt and notes he continues to plan to kill himself. It's very straightforward, right? The hold needs to continue. Let me throw in a few curveballs here at this point. Let's say that Mr. Doe wants to get out of the hospital and not be on a hold. He may say that he's not suicidal. He may say that this was all a big mistake and he just had a bad day, and he realized the error of his ways, and he's sorry to inconvenience everybody. And he'd just like to be sent home so that he can have a happy, good life. He may be lying. He may be telling the truth. He did state, however, just before that he wished he had been successful in his suicide attempt. He may have been overheard talking with another patient and learning how to break a hold. Tell them you're not suicidal. Tell them you're fine. Tell them it's all a mistake, etc. So you, just as Carmen says, you need to have evidence that he's future oriented. You base it on details that he shared in the past and the present. Say more, Chiara, about a TOMM. I'm not familiar with that. I think you're making a joke, but I can't, I don't know the reference. Oh, a validity test. Yeah, yeah. Okay. All right. So you do just, oh dear, I'm sorry, Rebecca. Okay. So you have to be very conservative and cautious about this. When in doubt, don't break a hold. When in doubt, put someone on a hold. What if, God forbid, they were lying to you, manipulating you, tricking you, seducing you, threatening you, etc., and they were really planning to do the deed? suicide or homicide, etc. Why take a chance with that? When in doubt, be conservative, keep them on a hold. So there are cases, this is not the case for Mr. Doe quite yet, although it will be down the road a little bit. Yeah, Janelle says usually they would refer back to chatting, staff observations. That's very important, is to get other input. You don't want to make all these decisions totally on your own. You want to make this as a team effort. And frankly, you want to be really good about this judgment because you're depriving Mr. Doe of his civil rights, keeping him in a hospital against his will. So you want to really be thorough about this, and you want to get input from other people. And you don't want to be out on a limb yourself. That's just foolish and injudicious. Okay, so, but you may say to a patient that you know, or that you have confidence that you can, verify what they're saying, that you may want to switch them to a voluntary status because that's more therapeutic, right? They choose to be there. But there is certainly patients, it does happen not infrequently, that a patient who's been on a legal hold and is now on a voluntary status immediately asked to be discharged against medical advice. An AMA discharge against medical advice. And that patient doesn't automatically get discharged. They are then evaluated by the nurse, the charge nurse, and the doctor on call of whether or not their cause is just. If they actually believe the patient when they say they're fine, and 99% of the time, the patient is either put on a new hold with the original time going back to the original time of the original hold so that they don't add time to their hold, and they're kept on it. So it's very clear to patients and through the grapevine of patients talking with each other that this doesn't work to lie about it. When they're also told they'll discharge AMA, their insurance company may refuse to pay the bill. Yeah, I guess that's true. I hadn't thought of that aspect of it. I kind of don't like that. That one, we tell them that routinely, the insurance won't pay for it. I'm just not sure that's true, but you may be right. That would be manipulating the system and the insurance company. You, in good faith, the hospital, put them on a hold and was taking care of them. It seems hard for me to understand an insurance company saying they lied and you guys didn't pick it up. But CEO, yeah, I could see that. That's more of an administrative sort of, excuse the French, but to me that's a little bullshit. And I'd rather deal with this in a much more straightforward, transparent manner. You said just before this that you had been suicidal. You told your roommate who's looking out for your interest, and they told us because they were worried about you. And now you're telling us that it was all a mistake and a lie. Well, we can't take that chance with your life. We're not going to break the hold. I'd rather it be that way, but hey, manipulation, sure, why not? To keep them safe. It reminds me of the old line, when it comes to your safety, all bets are off, in terms of who you talk to and how you get the information. Who told you that? They didn't tell me who told you that, and I'll confront them that I wasn't, that I was suicidal. No, you don't go for that. You don't need to participate in that kind of dialogue. I have said to many a patient over the years, when it comes to your safety, all bets are off. If you call me up and say that you're suicidal or you've just taken an overdose and I call 911 and you get angry with me for doing that, tough. That's my job. You can count on me every time that you call me in an emergency and tell me that you have attempted suicide or you're planning to commit suicide. You can count on me to call 911. You can guarantee that that's what I'll do, because that's what I'm your psychiatrist. I'm your bottom line. All bets are off when it comes to your safety. I don't excuse it. I mean, I don't have to justify it, etc. All right. So let's go back to Mr. Doe and his chart. Mr. Doe is anxious and he's got issues of insomnia. He's pretty upset being in the hospital. So page 3.2.5 is an informed consent sheet for anti-anxiety medication. This is the routine hospital form, one medication per consent. In this case, it's lorazepam Ativan. It gives the range of the maximum dosage, 4 milligrams and up to 4 doses by mouth for the symptoms of anxiety or insomnia. The doctor's signature is there. The patient signature is there, that he understands it and he consents to it. On the second page of this, which is the other side of the back-to-back pages, is the potential side effects that could happen with a benzodiazepine, such as drowsiness or depression, lightheadedness, dry mouth, disinhibition. What are the alternatives if he doesn't want to take this medication? Well, it's self-relaxation techniques. What might happen if he does not take this medicine? He might not improve, or he might improve. There's cautions about overdose, unconsciousness, and that they could be habit forming over time and withdrawal, etc. Moving on to the next page is a medication consent sheet for antidepressants, because as we will see in the hospitalization in the assessment, that Mr. Doe is depressed. So it's decided by the doctor, Dr. Smith, to prescribe Effexor venlafaxine of a maximum daily dosage up to 225 milligrams a day and 2 divided doses for the treatment of depression and anxiety. Mr. Doe signs this, he consents to it. Page 2, the other side of the page, is advantages to taking it, alternatives. Perhaps he would choose St. John's Wort or something over the counter as an alternative. Here are the potential side effects and cautions. And don't mix it with alcohol, as you may have adverse effects. All right. Moving on in the chart, this is page 3.2.9, the admission orders to the adult psychiatry unit. You're Dr. Smith. The internist who does the history and physical is Dr. Jones. He's brought in on a 5150, danger to self, 72-hour hold. His diagnosis, even provisional diagnosis, is major depression, recurrent. Could these pages be put on the screen, Chara? The answer is no, and I'm really sorry. I don't know how to do that. We can only go to the references for this material. It's within the, PowerPoint slide 65. But what I'm going through is a paper chart in the reference section 3. And I haven't figured out over the years how to do this in a more convenient fashion, and I apologize. Okay, so when you're admitted to the hospital, you often get admission labs to make sure that you don't have any medical reason for or complications for your mental health presentation. So he gets a CBC, make sure he's not anemic, a chemistry panel, a thyroid functions, hypothyroidism, right, could cause depression. He gets a test for syphilis, the RPR. His diet is regular. His vital signs are twice a day for the first 3 days. And he's put on a certain level of suicide precautions. And those tend to be 4 levels of nothing at all to need to be in line of sight at all times, and gradations between. Remember, he said that he's suicidal and was sorry that he didn't succeed. So he's put on level B, which depending on the hospital has different ways, but it would be, he'd have to have his door open, his bedroom door open, and be able to be observed on 15-minute checks. But he wouldn't have to be so acute as to be forced to be in the day room all the time, even sleep in the day room under line of sight by the staff at all times.
Sorry, Doctor, to interrupt. Would you want my help to share the material you are talking over?
Can you do that easily?
Yeah, it's very simple. Same way as you shared your slide, you would just share that screen. You just get out of the fullest.
Aiden, if you can do that, that would be great.
Yeah. Let me just unshare what you just
Sure.
shared, and then now you choose the other material that you want to talk over.
The trouble is, I don't have access on the computer to that material. All I have it is in paper form. So you say that you can share it, but I can't.
Would you? Oh, do you want to share the reference ones?
That's what you're talking about, isn't it? Putting the pages on the screen.
Yeah, I can put the pages on the screen, and then I have to like follow through with you.
Okay. Yeah, you'd have to stay with me and switch it over time because I won't have control of it.
Okay. Let me just see if I can try that.
So hold on, folks. Hey, maybe this might be a good time for our first break, and Aiden can start working on this during this break, and we'll start up again at 2 minutes after the top of the hour. So why don't we take a 10-minute break?
Which is it still reference section 3? Which section is it?
Reference section 3.
Okay.
And it's actually, we're on page 3.2.9 within reference 3. 3.2.9. It's about 9 pages into it.
Okay.
And I think, Aiden, I just figured out in my head how to do this myself the next time, but I don't think I can pull that off this time because I'm on a laptop computer that doesn't have the references in electronically.
Well, I have it. I need to just resize the page because the height and
Ah, doesn't
the
quite
height of
fit.
the page, yeah, doesn't quite fit the.
Maybe you can, maybe it'll be good enough.
Okay, let me just share it. You tell me how it works for you.
Sure, sure.
Okay, so we.
Hey, there you go. So that's good. So you're on page 9 of 26, and I'm at about page 11 of 26. Yeah, keep going, keep going. Yeah, keep going. We just talked about that, the antidepressant medication consent sheet. Is there any way I can control that, or do you have? Yeah, you're the only one who can control the flow,
Yeah.
but that's okay. Yeah, actually, I think it'll be helpful to the students. And in the future, I will figure out a way to do this myself. Frankly, it had never occurred to me, which is just nuts. I'm a little techno challenged, and I don't think through these things quite the way I should. Hey, this is good. See if you can do single page view, and it'll have the whole page. Yeah.
Well, probably.
No, no, it doesn't work.
No,
Yeah.
no, it doesn't
Okay.
work this way.
That's all right. That's all right. So we get about half the page, and
Right.
that's useful. It just means that, oh yeah, you could zoom out or zoom in. Actual size. Yeah, I'm not sure. No, it's a little better. Well, let's let's go with the art of the good enough, which means that we ought to accept it as is. And then, Aiden, you'll stay with me on this. We're not going to do this for too much longer. It's only 26 pages total. And when you and I will tag team this, where I'll start talking about it and you'll start moving down that page. How's that sound?
Sounds good.
Okay. So go to go to the next page, page 12 of 26, or actually, I think page 13. Yeah, get through that page to page 30. There we go. Okay, so that's the order sheet. Let's stop there, and because we're officially on a break, and for a couple more minutes, and we'll start there in about 2 minutes.
Sure.
And then we've got half the page, and then you'll bring it down to the other half of the page, and then we'll move on to the next. Actually, this is going to work out very nicely,
No problem.
considering.
No
Okay. This, ladies and gentlemen, for those who are still listening to me, I'm going to give a quick aside of a topic that I invented in medical school that fits very appropriately here. It's called the art of the good enough. And the good enough, so when I was in medical school and had Monday morning tests pretty much every Monday morning for 2 years in the more academic part of the first 2 years of medical school, we were presented each semester with probably a 2 to 3 foot stack of textbooks that we had to buy and read on everything related to medicine, hematology, etc., anatomy, physiology, etc. And there is just no way that one could master every page unless you were maybe on the spectrum and had a photographic memory, which I don't, I'm not, and I don't have. So I learned pretty quickly the art of the good enough, and that is the good enough job is a done job. You get through the material. You may not have learned every detail of the material, but you have mastered a vast majority of the material. How do you do the art of the good enough? You figure out how much time you have to learn and absorb the material, and you divide it up. So every night in medical school, I would spend 15 minutes to a half hour preparing for the next day, saying, I have X number of hours tomorrow to learn X amount of material. I also have to put into this sleep time, eating time, downtime, dog walking time, sanity time, because I can't do this 24/7, I'll burn out. So you have to maintain. And that would mean sometimes the material for the next day would be 200 pages, sometimes it would be 20 pages. How much could I, of that material, could I gather and then move on to the next day and the next day and the next day? It was a very kind of, in one way, rigid way of learning in medical school, but it kept my sanity. I finished medical school in the top 1/4 of the class. I was never aiming to be the top of the class. I was not a brainiac, but I was damned sure and determined not to be in the bottom of the class. And I wanted to be somewhere above the 50% mark. That was my own personal goal. It fits with my academic career ever since elementary school, where I was always a minus, B plus student, and finished everything, got my degrees, got my diplomas, passed my boards, et cetera, and it was the art of the good enough. The good enough is a done job. It's not a perfect job, because perfection is the enemy of this whole process. To be perfect drives you a little bit nuts unless you're a total brainiac or on the spectrum or on the spectrum. And anyway, so Aidan came up with a solution for us getting through this material. It's not perfect, but it's an improvement and it's good enough. So I appreciate that, Aidan. And I appreciate you listening to my soliloquy about the art of the good enough, which I embrace in life and recommend to others. Get through it, be done with it, do a good job. And also all the good ethical standards that we talk about of do good, don't do wrong. All right. So yes, Janelle, thank you, Aidan. Okay, so we're back into this. We've had our break and we're looking at the admission order sheet. You see what I had said about his legal status. John Doe's legal status is a danger to himself. His provisional diagnoses, major depression, recurrent severe. He has hypertension. He has problems of primary support. We learned later that his wife recently left, etc. Aidan, start moving down this slide to the second half of the sheet. And you'll see the labs, as I mentioned, the chemistry panels, CBC, etc., the regular diet. You'll see that, by the way, all patients are searched for contraband, for bringing weapons onto the unit, for razor blades, for means of hurting themselves. And you, depending on how well or how much you trust or don't trust the patient, you might do a body search, and you might have them strip their clothing and only be in underwear, and even check under the underwear, just like sometimes, some of the screening for Homeland Security stuff at airports. If they take you into a side room and think that you're at significant risk. Okay, the other part of this is the allergies. Does he have any allergies to medications? The other part of this, line 13, is medications. You're giving him Tylenol as needed. He's a smoker, so you give him Nicorette gum. It was such a big deal in hospitals 20 years ago to ban smoking. Now it's routine, and we would always give smokers nicotine replacement possibilities. There's a whole discussion of whether or not you should help people quit smoking when they're going through a mental health crisis or a substance use disorder crisis, whether you're reinforcing addiction, etc. But that's for another day. Then there's Mylanta and milk and magnesia as needed for nausea, constipation, etc. So the medications that Mr. Doe is scheduled is hydrochlorothiazide, a diuretic, antihypertensive, 25 milligrams in the morning, and he's given PRNs or as needed medications for insomnia of a benzo, Ativan. Okay, you notice that Dr. Smith signs it, dates it, times it, and that it's noted by the nurse. Okay, so let's move on to the, yeah, very good, thank you, Aidan. The next page, 3.2.6. I don't know why we didn't do this before in all the years past, Aidan. This is very smart. So this is the handwritten orders. The previous page was mostly check boxes. So these are the blank order sheets. And we're starting Mr. Doe on Effexor, 37.5 milligrams orally, PO, QAM in the morning. And he's then served a copy. That's the third day of his legal hold of the next hold, the 5250 in California, the 14-day hold, with a copy given to the patient. It's all documented in the orders. Moving down, Aidan, to the next section of this page, we are seeing how that's it. Perfect. We're seeing how on the next day, he tolerated the initial dose of Effexor, which is a good idea to try a low dose of an antidepressant medication as a test dose to see if he has any untoward reaction to it. Some patients are exquisitely sensitive to medication, and they'll have nausea, vomiting, dizziness, low blood pressure, etc. And you can't continue them on the medication. But he did not have that reaction. He tolerated it well. So you start moving it up rather quickly to a therapeutic dosage. So the next day, the 9th of January, it's increased to 75 milligrams in the morning, double the dose. Now, this is what I was alluding to earlier. Partway through the hospitalization, you feel confident and comfortable with Mr. Doe being a voluntary patient. He's not demanding to leave the hospital. He's not expressing suicidal thoughts. In fact, his suicidal thoughts are receding. So you change his legal status to voluntary. You want to do that therapeutically as soon as you feel comfortable doing that, because you want him to buy into the therapeutic alliance that you're trying to build and have him there for his reasons, not for your reasons. Now, you're all prepared if he were to schnooker you and try to get himself discharged against medical advice by having him reevaluated at that moment by nursing staff and by the on-call doctor to return him to a hold. but in this case, it works out well. You also change his suicide precautions to suicide level C precautions, to suicide level, to suicide level C precautions from suicide level B precautions. And in my hospital, that meant that he could have his door closed at night, so he wouldn't be disrupted all night long, but he still would have 15-minute checks. The nurse would stick their head in the door every 15 minutes throughout the night and chart it to make sure that he was breathing. What you do is you stand at the doorway and see that the chest is rising, etc. You don't shake them awake or anything like that, but you do observe them on, in our case, level C precautions. Okay, moving down, Aiden, to the next section right there. Now the next day, the 12th, he's tolerating the effects are well, so you now increase it to a to a more therapeutic dosage of 150 milligrams in the morning. And you change his suicide precautions to the lowest level, which is level D, which means that people are aware that he came in because he was suicidal, but he's no longer on any strict precautions per se. He is on a level of precautions. I should be precise about that, but it's the lowest level. Also, on that day 12, you're feeling comfortable enough to test the waters to see how he does off the unit, out of the hospital. And so you write an order of off ward and out of hospital privileges with staff, ASD at staff discretion. Let me just say a word about that. And this is a little controversial with managed care companies who say that if a person is able to be taken off a psychiatric unit, that they feel they have the wherewithal to be safe and not harm themselves, they don't belong in the hospital and further treatment should be denied. I have always strenuously objected to this line of thinking on the managed care company's part to deny days, because how in the heck do you know if someone is ready to be out of the hospital unless you test the waters in some fashion, unless you try them out in a careful, judicial way? So what I've often said to staff and patients is, in morning rounds, I say, I've checked with the patient. They seem to be okay to be able to test the waters and see how they're doing off the unit. How about the next time, nursing staff, that you take a blood sample or urine sample to the hospital lab, that you take a patient with you and as an outing, just to see, or you take them to the hospital cafeteria for a cup of tea to get off the unit and clear their head a little bit, get away from the pressure of the unit, if you will, the locked unit. If that works out, then you consider going on a outing outside the hospital to sit on a bench outside the hospital, the front door or the patio. In our hospital, which was next to Golden Gate Park, we would often take patients across the street to Golden Gate Park and sit on a park bench and be part of nature for a little bit and see how they're doing. It was also a very effective way, by the way, of doing therapy on a park bench for someone who, some of my patients that were on the spectrum and had trouble with eye contact and walking in the park while talking, or sitting on a park bench, not staring at each other, but looking out into nature, was often a friendly and respectful and therapeutic way to do therapy. So you test the waters and you leave it up to the staff to make that decision, because they're there with them each shift 24/7, and you give them the wherewithal to make these clinical decisions themselves. It empowers them, and it's good for the patients. He's doing so well that he's discharged about 5 days, 6 days after admission. Okay, let's move on to the next page, Aiden. Very good. Okay, so this is a multidisciplinary progress note sheet that is done on a daily basis for each patient. It starts on his day of admission, and take a look at it. It reinforces that he's on suicide precautions and what level of suicide precautions. Level B, observed every 15 minutes when asleep. Etc. Let's keep moving down. You'll notice that the nursing staff signs off on this, initials it. Also, when does he get his blood pressure checked? Yeah, you can stop right there. Thanks. He didn't eat any breakfast. That's B. He ate 25% of his lunch and he ate 25% of his dinner. That's on day 1. He's pretty depressed and withdrawn. He's given Ativan, a PRN, 1 milligram at bedtime, and he's given Tylenol, 10 grains for headache. His vital signs are done and charted according to the day shift, the PM shift by the people who did it. He does his hygiene and washing himself, etc., and number of hours of sleep. This is all quantified in the medical record because you want to know these details to see how he's doing in general. Is he taking care of himself? Is he doing proper hygiene, or is he so withdrawn in a fetal position in bed? That's of concern. Keep moving down this sheet, if you will, Aiden. And here's his mental status exam for each shift. On the day shift, the arrow down says that he's everything is fine. In terms of, here, look at the comments. He's fully oriented times 3. He's clean and tired and anxious, rambling in his thought process. He's focused on no hope as his thought content, not unusual for someone coming into a hospital after a suicide attempt and quite depressed. His affect is blunted. His insight and judgment are both poor. You want this guy to stay in the hospital for a while. And the different signatures of the nurses on the different shifts. Okay, moving on. We're moving to the sheet that has essentially SOAP notes, subjective, objective, assessment, and plan. And this is his SOAP note from me, or I'm Dr. Smith, I think, the first day. So I reviewed the chart, I discussed with staff, and I interviewed the patient. What did I actually do? Subjective, why did the police stop me? Why did they stop me? Complains subjectively, he complains of hopelessness, expresses suicidal thought. He had a plan to buy a gun and shoot himself, but he decided on the beach instead. He focused on job loss and his wife leaving him, which had been recent events in his life. Objective, this is where you put the mental status exam, MSE. He has a blunted affect. He's rambling. His thought processes and thought content are focused on suicide. His judgment, insight are poor. He's tearful in one-to-one. He has no future orientation, right? Okay. Janelle, I needed the good enough speech. We're pushed to the limit at times when it's not necessary to succeed. Absolutely right. In fact, that line about, perfection is the enemy of good enough. I just like the idea of, and it's probably egotistical on my part, of better than average, but not perfect. By the way, for what it's worth, that came from a a Berkeley professor, engineering father, who I'd come home from elementary school with my grades. He'd look at my grades and he said, "What happened?" And I knew exactly what he meant. I got an A minus instead of an A. Um, and it was like, God damn, Dad, is that what I have to do? So it was my anti-authority thing against that perfection. And my poor dad had been left by his mother at 5 years old and was always trying to, be perfect and all like that. God love him. But it kind of tortured him and everybody around him, including his children. So it was something that I learned pretty early, is the art of the good enough. Lighten up. All right, moving on. So back to the mental status exam, you want to paint a picture. This is a picture that you want for purposes of the legal hold, for insurance purposes, and also for good clinical purposes of what's really going on. You are the eyes and ears in this chart. So you want to say that he's got his head in his hands. His staff report minimal milieu involvement. He isolates in his room. He's in a fetal position in bed, facing the wall, rocking. This is all very important documentation. His sleep is poor, so he's given Ativan to help with that. Okay, moving down to the bottom of the page, Aiden. So 5150, and he remains DTS, danger to self. He's tolerating the effects, sir. This is the assessment. What's your plan? So you're going to continue him on suicide B-level precautions. You anticipate raising the antidepressant the next day. You're going to continue with individual and milieu treatment, and you're going to focus on his coping skills. You're going to use CBT, and you're going to help him decrease his suicidal thoughts. You're going to change his status to another hold, the 14-day hold in California, the 5250, and you're giving him a copy. Everything is totally transparent. How much more time do you anticipate that he will need to be in the hospital? You project that. You think 5 to 7 days based on your experience with similar patients. Very good. Okay, moving on, Aiden, to the next sheet. This is the MAR, the medical record form, medication record form. And it's filled out by the nursing staff. So here we have his hydrochlorothiazide, HCTZ, and his Effexor. It's documented who gave it to him, when is it dispensed. They sign their initials. And at the bottom of the sheet, Aiden, let's go down to the bottom, we see what their initials stand for. That's Nurse Baldwin, Nurse Gibson, and Nurse Lane, right? Okay. So those are the routine orders, medications. This next one is the PRN order sheet, PRN medication record. And so he has Ativan ordered. He's taken 1 dose on the 5th, 1 dose during the day shift on the 6th, and 1 dose at bedtime, and the night shift, or the PM shift, which is 7 to 11, 2 to 11. Is that right? Yeah, I think so. And he's given Tylenol, and he's given milk and magnesia on his 4th day. Okay, moving on. Now, let's say this is good. Okay, so what if there was an error? What if he had an adverse reaction? What if he had hives related to the medications? You would want, this is part of Joint Commission stuff too. You want to report this, any adverse drug reaction on this sheet. He didn't have anything, but this is what you would do. The suspected drug, the adverse reaction noted, whether it was akathisia, urinary retention, hypotension, etc. Let's move down this sheet, Aiden. You'd want to make sure the doc was notified of this so they wouldn't continue prescribing it, come up with an alternative. Who was the reporter and how was it dealt with in review later? Okay, moving on to the next sheet. This is the incident report where there was an error in giving the wrong medication to the wrong patient. So we take this very seriously in hospitals. We follow up on it. What is the severity of the error? Nothing happened bad, but this sheet is in every chart and is filled out if mistakes happen. You never hide mistakes in a hospital. You're always honest and transparent, and you learn from the mistakes. So what level of error? Was it so severe, level 3, that there were significant effects? Did it kill the patient, for example? And what was the problem? Was it the wrong medication, the wrong dose, incorrect time? Was it omitted? What was the actual problem? And then moving down on this sheet, what was the cause? Maybe you couldn't read the doctor's handwriting, right? And they gave 10 milligrams instead of 1 milligram. Maybe there was something wrong with the order writing itself beyond handwriting, etc. Maybe they weren't checked for allergies properly, and they were given lisinopril. I'm allergic to lisinopril, so I can pick up this on this one, and got hives with it, but they never asked me at the beginning, are you allergic to any medication? So was it a transcription error done in the pharmacy department? Did a pharmacy tech pick up, do it wrong? Or the pharmacist, etc. Was it misread? What was the reason? So these are very serious and not taken lightly. Any mistake is questioned. Okay, now let's move on, Aiden, to the next one. History and physical. Okay, so this is actually not Mr. Doe's history and physical. I pulled out a real history and physical from my files, and this was my, at the time, 58-year-old patient who I hospitalized 4 to 5 times a year for 15 years. And so this was a pretty, she had called me up. Well, we'll see. We're going to read through this together. I just took out her identifying information, but gave you the gist of it clinically. So she's 58 years old, she's divorced, she's a white female, she has 3 grown children, and she lives alone somewhere in the Bay Area, funded by Medicare and Medi-Cal. And it was a voluntary admission with suicidal thoughts. Now, why a voluntary admission? Well, we'll see as we read through why I didn't put her on a legal hold to begin with. So at this point in her career with me, her professional patient career with me, she had had probably 150 admissions. Now, not all with me, but as I say, about 5 a year for 15 years. So that works out to be, about 75 admissions. And this was toward the end of it, around 2001, when she stopped being my patient after, within months after this. I'm just going to read this out loud with you. One of many 150 plus psychiatric admissions for this 58-year-old woman who carries a psychiatric diagnosis of schizoaffective disorder and borderline personality disorder. She was admitted on the afternoon of January 22nd, 2001, after calling her psychiatrist, me, stating that she could no longer guarantee her own safety, that she was obsessed with the thought of overdosing on all of her Klonopin medication, her benzo, approximately 30 milligrams. She'd been recently hospitalized with suicidal ideation and self-destructive behavior of delicate cutting just a week prior, 2 weeks prior. On return home, she opened the mail to find an eviction notice. This is a woman who prided herself in her home, her independence. She was got Section 8 housing, subsidized her housing, and she lived in a apartment complex in the Bay Area, 1-bedroom apartment, quite lovely actually. And it was her sanctuary. And her landlord, in his ill wisdom, decided to evict her, get rid of her, because ambulances came to the apartment complex periodically to pick her up, police, etc., and he wanted her out. She went on a crying jag, became emotionally overwhelmed, unable to cope, enraged with the landlord, threatening suicide. And just to put it in context, she had been hospitalized since the age of 29 3 to 5 times a year, and now she was 58 years old and presented in a similar manner. So for the past medical history, I say sealed record. There's no need to go through it in any detail. Her medical history is that she had gastrointestinal esophageal reflux and peripheral neuropathy. She was followed by an internist and a neurologist. Let's keep moving down. Good enough. Thank you, Aiden. So her admission mental status exam, she was irritable, she was tired, she was angry. She admitted to suicidal ideation, self-destructive ideation, but contracts for safety in the hospital. And notice how I highlighted that. I'll make a point of mentioning that, but I want to finish the mental status exam. She admitted to auditory hallucinations. Her thought processes were normal. She felt overwhelmed. Her judgment was fair. After all, she did call me. Her strength was her intellect. She was a very bright person, and her insight was fair. This contracts for safety in the hospital business. She was the one who taught me that contracts for safety are bogus, because a contract by its legal nature is an agreement between two parties. Well, you don't contract with a suicidal patient to not be suicidal, or if you do, it's not a real contract, right? Because they're coerced into doing it. What are they going to say? No, I don't contract with you. And then they're put on higher suicide precautions, more restrictive. Their door has to be open. They're always in the day room, observed, and they have no privacy. They're not going to go along with this, except to agree with you that they're not suicidal, just to get you off their back. She taught me this in a very sort of epiphany way after one weekend, when I came to see her on the Monday morning. An on-call doctor had seen her over the weekend, checked in with her, and he said to her, Ms. Smith, do you still contract for safety? Yes, I do, doctor. She said to him without even looking at him. And she was kept on her lower suicide precautions. And I said, she brought it up on Monday, and she said, Dr. Brady, you need to change this policy about no suicide contract business. It's bullshit. It's bogus. What am I going to say to that guy that I don't even know that you have see me over the weekend for 30 seconds to check if I'm safe? What am I going to say other than, yes, I'm safe? She said, it's coercive, it's bogus, it's not genuine. And it persuaded me pretty quickly, I was heading in the direction anyway, to shift to a safety plan, if you will. Not a suicide contract or a no suicide contract, but a safety plan. And a safety plan is one that we use with children and adolescents often, where if I have the following feelings of feeling unsafe, feeling scared, feeling like I'm going to hurt myself, feeling like I'm going to do something to harm myself, I will alert trusted people. I will alert my mom and dad in the case of a kid, my grandma, the neighbor, my auntie, etc., and let them know. They're brought into this safety plan so that they know not to overreact when I check in with them. Hey, mom, I'm feeling unsafe. Not to call 911, but to say, what's next to do? I'll be with you during this time, this little crisis hour or half hour. Let's do something together. Let's do a jigsaw puzzle together. Let's get busy doing other things. Why don't you help me clean house? Or let's do some gardening, or let's do some distracting activity that's positive. And what if it doesn't work? What are we going to do next? Well, plan C is we're going to call your doctor and check in with your doctor and get their input and support and help. And the doctor will listen to you, even though it's an emergency and in the middle of the night or whatever. Whoever's on call will listen and help decide what's the right thing to do. Can you get through the night okay? Are you going to be okay? Do we need to get you into the hospital right now? Do we need to call the police right now to stop you from, jumping off the roof or something like that? A safety plan. A safety plan is much more reasonable. But at that time, we were still stuck on contracts for safety because it looked good to the hospital. The hospital was covered. They contracted for safety. It appeared legal, although it wasn't, because it wasn't a full contract per se, right? All right, enough said on safety plans versus no suicide contracts. Try to avoid no suicide contracts and stick with safety plans. It's much more honest, respectful, and useful, helpful. All right. Brief formulation. 58-year-old female has decompensated due to the stress of losing her housing. This taps into abandonment and rejection issues. Her symptom complex is consistent with schizoaffective disorder, borderline personality disorder, character organization. All right, diagnoses. Schizoaffective disorder, borderline personality disorder, the GI symptoms, peripheral neuropathy. She has an inadequate primary support system, and her global assessment of functioning. It currently is very poor, and the past year has been a little bit better. What's the treatment plan? We're going to stabilize her. We're going to put her on some precautions for suicide because that's what brought her in. We're going to get a neuroconsult. The neurologist is considering Lamictal for both her neurologic situation with her peripheral neuropathy and also for mood stability, given her schizoaffective disorder. So how will the diagnosis section read with the DSM-5 standard? Right, so this is pre-DSM-5, and we are no longer using these clean axes with DSM, so you write out the diagnoses, right? That's how you deal with it for DSM-5. Let's shift now, Aiden, to the next page. And that's a very brief page. Remember, I got this all on one side of one page, which is pretty amazing for this patient in this hospitalization. We anticipate a 3 to 5 day hospitalization, return her to outpatient, where she saw me 3 or 4 times a week at that point. And then let's now move to the next page, Aiden, page 23 of 26, which is her discharge summary. I didn't put in any of her chart notes. because I wanted to just illustrate a discharge summary that is a page and a half total. So the very first time I wrote a discharge summary for a child was, I think I mentioned this last year, was like 20, 25 pages with references, and the supervisor threw it back at me and said, "This is worthless. No one's going to read this. Cut to the chase. Do this and use the fewest words possible." In fact, it is similar to, if you go to law school, it's similar to the legal brief course that you take in law school that has you learn how to write only the pertinent information with the fewest number of words in the most easy to understand language with not many syllables. Dummy it down to a grade level of about 10th grade. By the way, there's a Microsoft software that's built into every Word program that you can decide, or you can figure out if your writing is at what level it is, what grade level it is. And they recommend to do it at 9th grade reading level, and you can kind of go up to 10th grade. So you try to keep it simple and straightforward and readable and fast. So here we have, I'm repeating in the history and physical findings what brought her into the hospital. It pretty much repeats what the history and physical was to begin with in a Reader's Digest condensed form. So let's shift down, Aiden, to the course of hospitalization, the second half of the sheet. And let's see how she did in the hospital. This is her approximate 5-day hospitalization and what happened. So she received milieu therapy, individual therapy, and group therapy. She was started on Lamictal to aid with mood instability and peripheral neuropathy pain. She tolerated the medication, and she had some itching. It wasn't clear what caused the itching. And Lamictal, as you know, can result in Stevens-Johnson syndrome, the sloughing of your skin, and death. So you have to be worried when someone's saying they're itching. It wasn't clear whether it was due to the medication or not, but it resolved and there was no rash. But she was observed closely. And there was a plan to increase her dose over time in consultation with their neurologist. And she did generally well during the hospitalization, progressed each day toward a greater level of emotional stability, not only and a greater sense of increased coping, but ability to rely on help from others. At the end of the hospitalization, through progressive passes, testing to see if she could handle a lower level of care, she demonstrated that indeed she could, and she was discharged to home on the 8th hospital day. You do a risk assessment at the time of discharge, showed her to be not at risk to herself, able to be safely treated at a lower level of care. And the formulation, we'll read that and then move on to the next page, is that she had symptoms characteristic of schizoaffective borderline personality disorder. She decompensates with stress, which was the eviction and or threat of eviction. She recompensated with the higher level of care in the inpatient setting. There's her discharge diagnoses, and here's the treatment plan, the discharge treatment plan. She was going to continue with the Lamictal, which was going to be increased. Okay, now I'm tuned in here. She was, this was a patient who routinely, as part of her character organization, would fire me routinely. and say, and she would, earlier in her time, she would call me up and say, I've had it, I can't cope anymore, I'm done, goodbye. And this would be a midnight call on my either at times I had, when I had a service, and at other times voicemail later on. And she would be heading for the bridge or heading to wreck her car or something like that. And I'd call 911, and she would always be furious with me, always fire me. And I'd always say to her, you're not allowed to fire me while you're in the midst of a crisis. There will be a time when we'll be finished with each other, and there will be a time for you to move on, but this is not the time in the midst of a crisis. So at some point after 15 years, she brought this up again, and she was not in a crisis. And we were pretty transparent and open with each other, and we both decided we were a little bit sick of each other. She was a little bit bored with me. I was a little bit bored with her. And also she had thought about the idea of working with a female therapist to work on some pretty primary issues for her. She had a really disturbed mother who she accused of physically and sexually abusing her as a child, and she was reluctant to get into that with me. I called a colleague of mine who was a clinical psychologist who happened to be the program director of an adolescent day treatment program that I was associated with, and said, would you be willing, when the time is right, and it's not right now, but maybe in 6 months to a year and a half, she may be willing to transfer to you to continue outpatient therapy and work on these other, perhaps more core issues related to her mother and the abuse that she claims to have suffered as a child. I had no doubt that she had these, was abused, but of course I couldn't swear to it. And at some point she said, and I even told her, I said, when the time is right, I think I found someone for you who would be interested in seeing you. And I've told her your situation, and she's willing to help and be there for you. And indeed, that's what happened after about 15 years. And I transferred her to her relief and to my relief. As I say, we were kind of sick of each other. And it actually was a very marvelous thing that happened, because she only had a few episodes of being hospitalized after that. And this was one of these hospitalizations after she transferred to the clinical psychologist. It happened only several more times. Then the event of my hospital decided to close its adult inpatient psychiatric unit, and that patients who had previously been seen at my hospital now had to be seen at a sister hospital across town in San Francisco with, to my patient, unfamiliar staff, etc. She'd gotten pretty comfortable with the staff in my hospital, and she toughened up and was never hospitalized after that again. She did have her crises, she did have her delicate cutting, she did have her suicidal thoughts at times, but she worked it out in crisis management with her new psychologist therapist, and who had a different style as I did. And it worked out very well. This was also a time, and I may have mentioned this before, and I apologize if I have, but it was just really cool. For probably 5 years before I stopped seeing her, I would bug her a little bit about, you know, you have too much time on your hands. You're not busy enough. You're not active enough. You sit there at home ruminating and stewing on your issues. And I wish you're so bright, and you really can move people and motivate people. I wish you would try to find a volunteer job helping others. There's nothing like helping others to get out of your own head. You have so much to impart in terms of knowledge and learning. I wish you'd work for a nonprofit who would somehow help people with mental health problems and get involved with them and be a volunteer counselor, a peer support counselor specifically. She hated my guts for suggesting that. She would rail against it. You just want me to do free work, and you want to get me off your back and all those things. And we would laugh together and say, yeah, that's part of it. So finally, she found such a job, that exact job, a full-time peer counselor position, volunteer with a nonprofit agency in San Francisco. And her job was to meet with young people after their first or second break of psychosis, often in their early 20s or mid 20s, and be a big sister to them, be a helper to them. And so she would take these often young men who were scraggly and scruffy to barbers and got free barbering to clean them up, would take them to the Goodwill or Salvation Army and find appropriate clothing and good reasonable clothing. She would prep them for job interviews and coach them, and she just loved it. It was as though she was mentoring and parenting her own children that were taken away from her when they were teenagers because of her psychotic symptoms. She was first hospitalized in her late 20s. So actually they were children at that point. And so they were left with the husband, who did a good job raising them as a single parent. And he then remarried, divorced and remarried, and the stepmom was involved in their upbringing. But my patient always was wistful about losing her adult children, who were quite reasonable with her. And although they had their issues, I met them. There were 3 of them, the 3 kids as adults, and they had their issues with their mom being psychotic. One of them even suffered from depression. But they did just fine. And she was able to find meaning and purpose in her life as an older woman by parenting these younger people with their mental health problems. And she was marvelous with them. She said, you couldn't pull anything that I haven't pulled myself, either consciously or not consciously, in terms of being suicidal or manipulating the system, etc. And at one point we laughed together because I said, geez, you haven't been hospitalized in months. And what's going on? What's getting in the way? And she said, it's you, God damn it. And I said, what? And she said, now that I have this volunteer job and I have to take 2 buses to San Francisco and be there at 8 or 8:30 in the morning, I have to get up like at 5 a.m. And I have to, get ready and be presentable and make sure I have long sleeve shirts on, because she was just a roadmap of scars from all her delicate cutting over the years. And she said, I don't have time to mess around. I don't have time to hurt myself or act out. I have to get to bed at night or I'm exhausted. So I have to get to bed at 9 p.m. every night. And you know how I used to cut on myself and burn myself on the stove and hit my head against the wall at midnight? I don't have time for that anymore. I can't afford the time to do that. I have people that depend on me. Well, it was marvelous. Okay. So let's take a break and And Aiden, when we come back from the break, we're going to take a break until 4 minutes after the hour. Yeah, Power Purpose, great story. It really is, and we fell into it. It was marvelous, and I've always said she was my second greatest teacher right after my brother, and that's just because we grew up together. All right, let's take a break until 4 minutes after, and then we're going to write out some prescriptions together. Okay, take a quick break. Okay, ladies and gentlemen, it's 4 minutes after the hour. Would someone just say they can hear me? And then we'll move on. Thank you.
Can't hear you, Doctor. Doctor,
Great.
how are we still staying on the same?
Yeah, let's stay on this slide for one more slide, and then we'll shift Aiden to a whiteboard, and I'll do some writing of numbers and things like that.
No
So,
problem.
but this is perfect for right at the moment. All right. So let's go back to John Doe, the patient, and these are 2 prescriptions for at discharge for John Doe. Remember, he was on the dual action antidepressant Effexor, which had been increased to 150 milligrams in the morning. And he was also given a prescription for Restoril. And let's just go through this. And this is the beginning of the section of the course on nomenclature and writing out stuff for prescriptions, and also abbreviations in charts. And I'm going to talk about that with a caution. I'll state the caution right now, and that is in an increasing demand for transparency and clarity, there is a need not to use abbreviations. There is a need to bring it to write out things in a chart so that it's not confusing, it can't be misinterpreted, and it can't be misunderstood and mistakes made. You just can't make medication errors. So you want to have a lot of redundancy, and you also want a lot of clarity. So let's go back to the 2 prescriptions on the top. Bring it down a little bit. Bring it the opposite direction, Aiden. Thank you. Okay, so we see that all the information from the prescribers, in this case, their California medical license number and their DEA number. Every prescriber has a DEA number, a federal DEA number, as do I. And so he's getting a prescription for Effexor. You notice how this is Xeroxed and the word void comes up. So if you ever bring in a prescription to a pharmacy that says Xerox, you're cheating, you're copying, etc., it's going to immediately say it's on special paper, and it's going to show up the word void so that the pharmacist knows that it's a bogus prescription, a copied prescription. So this is at the very beginning, the choice of the paper used in prescriptions is reflective of keeping fraud and copying and cheating from occurring. Okay, so with the Effexor prescription, we see that it's 1 PO QAM, 1 PO per aura by mouth QAM in the morning. Now the 1 has a line over it, a horizontal line, and a dot over that. And that's redundancy to show the pharmacy that what you meant was 1. So you don't just write 1, you put this line over it horizontally and a dot over that. You'll notice in the Restoril prescription, it's 1 to 2 with 2 dots and a line over the 2 vertical lines to have the redundancy that you mean 2. There's a lot of redundancies in this, and it's necessary so that there's no ambiguity or lack of clarity. Okay, you prescribe 30 pills. You write 30 in what do they call that? Arabic letters? 30, that pound sign number, and you write out the word 30. So there's no ambiguity there. Over on the right, you see that you're checking the box of between 25 and 49. That's the number of pills you're prescribing. So there is the redundancy there, right? Someone can't just add a 0 to it, making it 300, because it wouldn't match with the redundancy. How many refills are you going to give? Well, for Effexor, and he's not suicidal, he's pretty safe, you're going to give him up to 3 refills. How many drugs are you prescribing on this prescription itself? 1. So you circle 1. There is that. I mean, it's extra amount, right? The Restoril is a benzodiazepine, more abusable. So you don't want to give more than 1 refill. And in this one, you do 1 to 2 QHS every ora sinistra in Latin, a sinister hour, that's bedtime, PRN. Shoot, and I always forget this. The PRN is PRN is as needed per Rhea or Riza, I can't remember now. And now I've forgotten. Thank you, Jason. Pro re nata, right, is as needed. And then not to exceed, NTE, not to exceed, as the situation demands. Very good, Jason. Thank you. Saved by Jason. And not to exceed 2 times per week, because with the benzodiazepine and other abusable drugs, you want to quantify how many times they can use it. You don't want someone to take benzodiazepine every night for insomnia, because within a week or 2, they will become dependent on it and they won't be able to sleep without it, and our tendency is, and they have to increase the dose. So that if you keep someone from taking benzodiazepine for sleep more often than twice a week, they won't get dependent on it, or at least that's the thought behind it. I might have mentioned a patient I had with chronic severe insomnia, an adult. I'd had it for years and years. It affected his career, his relationships, everything about him. He had tried every self-relaxation, meditation, visual imagery, blah, 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 and got some relief, but never got more than a couple of hours a night for years. I put him on a pretty strict medication regimen of 5 different classes of medications that would help with his sleep, including a benzodiazepine, trazodone, an antihistamine such as Benadryl. I think I even used a barbiturate like Seconal once a week with him. He never took medicine from one family more often than every 6 days. And it worked for him for years. I was a savior to him. And it's what it took to get him through this. So I always wrote the prescriptions of never more often than once a week for that particular medication. All right. Aidan, let's move down to the triplicate, or the stimulant prescription, because I just want to be clear about that. This is another patient, Michael Taylor, I called him, and a dexedrine prescription for his childhood ADHD. And he took 2 pills twice a day. That meant 4 pills a day for 30 days, meant 120 pills. You write it out. He had no refills. You don't put refills on stimulant prescriptions in general. You have them come back and see you once a month, at least, if you're just doing medication management. You see the redundancy of the checkbox of 101 to 150 pills in the prescription. Number of products prescribed is 1. That's so if you left space, someone couldn't just write in another prescription and it as part of that piece of paper, right? Okay. Sorry, I missed the meaning of the serial number in the corner. Oh, so you have a medication pad with every prescription has its own unique number. So that way, if they're copied, that could be discovered. If they're lost, that could be discovered. What you want to do, just like you're writing a check from a checkbook, if you messed up writing the check, you would write void on it but keep account of it, right? So that it wasn't a missing check. What was that check for, right? So every prescription has a serial number on it to make sure that nothing untoward happens. All right. Ladies and gentlemen, we are finished with, nope, you're right. We have to show this last one. Aiden, this is a sheet on and it's kind of hard to see, but it's got all the details on triplicate prescription and why. Hey, very good. Transferring it or rotating it. You can see this is a mock sample for a triplicate prescription where you can actually write out up to 3 medications on that same prescription with all the details and number of refills and et cetera, et cetera. So a prescriber contracts with a local printing company that works with medical systems and provides you prescriptions with all your detailed information, your DEA number, state license number, everything pre-populated, if you will. All right. Let's now shift away from this reference and go to a whiteboard. And let me see if I can do that whiteboard. I think I can. And I'm gonna, there we go. Great, okay. So now I'm going to write out a whole bunch of things that have to do with medical charts and abbreviations, prescriptions, etc. But I'm going to do this by hand. I hesitate a little bit doing this because I have a bit of a benign essential tremor and don't have the most clean handwriting. So I try to write a little bigger as a result. It's also why my handwriting is very readable, because way back in the 3rd grade, when we were taught to learn cursive writing, I never got it down very well. And so my handwriting ever since to this day in my 60s is a combination of printing and cursive writing that makes it very readable. But now I'm getting a little bit older and have a bit more of a tremor, so I have to write bigger because I'm a little sloppy. But please bear with me on this. Okay, the first medical shorthand and accepted abbreviations we're going to do is numbers, right? Okay, so I mentioned in the prescription earlier that 1 is a vertical line, a horizontal line, and a dot over the top. So what would 2 be? We saw that on that prescription. It would be like that. Is that clear? Okay. And we'd go all the way up to, you know, it's all Roman numerals. So this would be 11. But you only do one dot on that because you are, you only do dots over the redundancy of the individual. So 3 would be 1, 2, 3, and 3 dots. Okay. In the newer way that we're supposed to do it, you actually are supposed to write it out. So what you write out is, this is where my bad handwriting, also with the mouse, I'm not very good at that. 1 and use an ampersand and 1/2. So 1 and 1/2, or 1 and, sorry, this is, I'm doing it too fast. 1 and 1/2. You actually write it all out. Okay. See why I don't like doing this. Okay. If you are doing 6, it would be Roman numeral 6 with 1 line over it. If you're doing 4, it would be 1 line and a V and a dot. Okay. Now we're going to do time. Okay. Forget that. Okay. So morning would be AM, right? Afternoon would be PM. Bedtime would be HS. Ora sinistra in Latin, the sinister hour, right? Ora sinistra. Now, many hospitals want you to use military time, and that means that you, instead of 5:30 a.m., instead you write 0500, or 0530 rather, for 5:30 in the morning, right? Okay. If it's 7:30 p.m., the VA system, of course, wants you to do military time. So 7:30 p.m. is equal to 1930. You just need to be consistent with what that hospital or facility does with this, in this regard. Okay. Now let's do prepositions. So before bedtime. So before would be ante, a with a line over it. After lunch would be P with a line over it. You know how in normal English we abbreviate with a W and a slash mark. Well, in medical terminology, it's a C, which I think is for Latin for con or with. And if it's without, it's an S with a line over it. So without. without, say, without a meal, something like that. Now, what's the route of administration? Okay, we've already talked about PO, per aura, right, is oral. You could do sublingual. Nicotine lozenge can be sublingual, SL. You can do it intramuscular, that injection, IM, intramuscular. It could be intravenous through the vein, IV. You could do it by rectum, like a suppository, per rectum, PR, right? You could do it nasal, and you write out nasal. How about a TB skin test? Would be subcutaneous. You do a skin pop of, you inject the material under the skin to make what's called a skin pop. In other words, a little bubble under the skin, and that's sub-Q, right? Okay.
Doctor, would it be okay if I quickly run the attendance poll?
Please. Okay, I'm going to continue. And okay, and we're going to clear these routes. Other medical terminology that you'll often see in medical records. You saw in that prescription that I said the temazepam is NTE, not to exceed, twice a week. NTE, not to exceed, right? Okay. When you discharge a patient, you might DC them. And DC also means to stop something. So you might stop a medication, DC Effexor today. You would use arrows to indicate increase, arrows downward to indicate decrease. The Greek sign of delta, boy, that's a terrible Greek sign. What I'm trying to do is make a triangle. There we go. Delta means to change, right? So you change a legal status, you change a suicide precaution level from B to C. You can also, refills can be an REF, refills. Now, when I say all this, I want you to be really cautious about this because we don't like to use this terminology anymore. We like to spell things out so that they're totally clear, but they are used all the time. So it's good to know what they are. All right, now I'm going to throw in some medical terms that are abbreviations that we're not supposed to use anymore, but we do all the time. So blood pressure is BP, right? Heart rate is HR. Vital signs, which means heart rate, blood pressure, temperature, vital signs. What are some abbreviations for common chronic medical conditions? Hypertension, HTN. Diabetes mellitus, DM. Boy, that's a pretty terrible D. Sorry about that. DM. A cerebral vascular accident, a stroke, would be a CVA, right? Cerebral vascular accident. You're doing a physical exam and you're noticing a lesion that is close. So it's proximal, or P, or it's distal, or the distal extremity. So proximal or distal. Let's do some abbreviations for mental status exam. Again, preferably you're going to write this stuff out. But again, it isn't always done, so it's good to know it. So are they oriented? Oh, are they oriented in all spheres? Person, place, time, and situation, oriented times 4. Or are they oriented times 2 to person and place, but not necessarily to time? What are their thought processes? TP. What are their thought content? What are they talking about? What are they focused on? Mr. Doe's thought content was on wishing he was dead. What is their insight? What is their judgment? What is their insight and judgment? Insight. Boy, sorry. And judgment. Are they suicidal? S. Do they have suicidal ideation? SI. Do they have homicidal ideation? HI. Or H. Are they homicidal? Are they paranoid? P. Do they have hallucinations? Do they have auditory and visual hallucinations? AVH. Or do they have auditory hallucinations? AH. Or VH, do they have visual hallucinations? Are they danger to themselves? DTS. Are they danger to others? DTO. Sorry. D's are not good. Are they gravely disabled? Unable to provide food, clothing, and shelter to themselves, for themselves. Okay, so these are all abbreviations used in mental status exams. All right, now let's talk about some weights and measures. So you have grams, right? You have milligrams. And how many milligrams are there in a gram? There are 1,000. So it's 1/1000th of a gram. What's a microgram? The mu, the Greek symbol mu. It's a microgram. It's 1/10,000th of a gram. So that means there are 100 micrograms in a milligram, right? And then there's nanograms. Whoops, that's not good. NG, nanograms. Okay. Volume, we have a liter. Normal nomenclature, we use the metric system. A liter is a 1,000 cubic centimeters. cc's, or 1,000 mLs, milliliters. A deciliter is 1/10 of a liter. So it's 100 cc's. Whoa, oh, sorry. 100 cc's. Or 100 mils. All right. Let's see if there's any others that I'm missing. Oh, okay. Let's do times. So a day is a D, a week, usually they just WK for a week. So say you give a medicine 3 times a day. So you do 3 times per day. So X equals time. Right? Okay. Every is Q, so Q day, every day would be a Q day, or Q day, lowercase q, shoot, Q day. QH, or you're giving medicine twice a day, BID, by TID 3 times a day, QID 4 times a day. Very hard to have somebody take medication, the same medication 4 times a day. The adherence rate is really bad for that. And then hour is H. Sometimes you'll do 1 hour, every 2 hours. Okay, here's some kind of random things on psych units having to do with charting notes. Remember how we talked about suicidal ideation? You might do like a no smoking thing, but for SI, no SI. You might have somebody in seclusion and restraints. That's supposed to be an S. S and R, seclusion and restraints. You may want someone to go on a pass, but it should always be at staff discretion. You never arbitrarily say that a patient's ready to go on a pass. It should always be up to the staff who's there in person and evaluating the patient at that moment. Leave it to the discretion of the staff. All right. I think we're done with this. Let's see if there's any others that I've forgotten. Oh, here's another one, within normal limits. That's often like the lab result is within normal limits, WNL. Are there any others? Looking through my pages. Nope, I think that covers it. All right. So I'm going to shift gears to back to the PowerPoint. And the slideshow. And we have covered the, now I'm on slide 67. And we have covered numbers, which always has redundancy in it, done in a Roman numeral way with a vertical line and a dot over the one, or, you know, if it's two, etc., 2 dots, 3 dots. So there's redundancy there. The time factors before, after, military time, regular time. The medical terminology that I gave you for some chronic medical conditions, CABG, hypertension, diabetes mellitus. The route of administration, whether it's oral, sublingual, intramuscular, per rectum, per nasal. And the measurement, the weight, grams, micrograms, nanograms, volume, liter, deciliter, cc, which is a milliliter, a cubic centimeter, thousandth of a liter. And then we went through the mental status exam with its abbreviations of S, H, A, V, H for hallucinations, auditory and visual hallucinations, oriented times 3, oriented times 4, etc. HS is bedtime, NTE, not to exceed. So here's a question for you that you might be asked. What if you're a pharmacist and you don't like the prescription that the prescriber wrote? You either don't like it because it's written improperly and doesn't make sense, in which case you should call the prescriber and clarify. God forbid that you would fill a prescription with an incorrect dosage of pills or directions when it was unclear. You should always double check if it's unclear, and it's frustrating and irritating to have to do that because it's time wasting. And often the prescriber wasn't clear in their writing of the prescription. And what if you didn't like the What if you didn't like the medication that they were prescribing? Do you have the right to refuse them? Do you have the right to say to that patient, I don't want to fill this prescription? The answer is yes. You as a pharmacist, you as a pharmacy have the right to refuse to fill a prescription if you don't feel that it's right. Either you feel it's unsafe, or you feel that it's wrong, or you feel it's substance abuse, etc. So I can't remember if I gave you this example when I was talking about children and adolescents. It actually was one of my adult patients where this adult patient, who was the wife of a judge, pretty prominent in the Bay Area, came to see me, and she had chronic fatigue syndrome, fibromyalgia, which at that time was still sort of being explored and kind of unclear as a diagnosis. Was it a crock? Was it real? Etc. And she had such chronic pain that she was popping Vicodin every 2 to 4 hours throughout the night and through the day to have some degree of pain relief. And she was becoming dependent on the Vicodin, hydrocodone. And she also was getting very poor sleep. It's one of my very first chronic pain patients early in my career. And I consulted with a trusted pain management doc. I called him up and said, I've got this situation. What do you think? What do you think I should do? And he said, why don't you put her on methadone? And I said, methadone? And he said, yeah, it's a long-acting opiate, and it will help relieve her chronic pain. She can also give it to her probably once a day, and she will have relief through the 24 hours. In a methadone clinic, you get methadone once in the morning. The long half-life, Dolapine is one of the trade names for methadone. It's taken once a day. And by the way, in a methadone clinic for opiate replacement, the average dose is approximately 80 milligrams a day, give or take, between, say, 40 and 60 milligrams up to 120 plus milligrams. The average is around 80. And he said, why don't you start her on a very low dose of methadone? I suggest you start her at 5 milligrams a day in the morning and see if that helps. Well, I wrote out the prescription, my very first methadone prescription. She took it off to her pharmacy. She understood, she got it. I educated her about it and the rest. And the pharmacist, who had been giving her, filling her prescriptions for years, balked and said, I'm not filling this prescription. And he just said to her flat out, I'm not filling this prescription. You have to. No, I don't. Yes, you do. No, I don't. So she called me in tears. I said, please give me the name and the phone number of the pharmacist. I called up the pharmacist. He was a little defensive at the beginning. He didn't know me. And I had to establish a rapport with him. I explained the whole situation in detail to him as a colleague. I said that I consulted with a pain management colleague who I trusted, and this is what he recommended, and that I wasn't sure whether this was going to work or not, but I thought it was worth a try and that she would benefit from it. He said, okay, I'll fill this one prescription for her, and how about you checking in with me later to tell me that things are going okay or not going okay? Well, I did. I called him several weeks later and said, it seems to be working well. She's getting a good night's sleep, and it seems to be helping with her chronic pain. related to fibromyalgia. And he said, okay, we're partners on this, and I'll continue dispensing it. And we were in like Flynn, and it worked out fine. But the pharmacist does have the ultimate right and power to decide whether or not to fill a prescription if they choose to or choose not to. And that's the bottom line. All right. Are there any questions, concerns? Shoot, I didn't bring up the chat, so let me do that. Sorry about that. Because you guys probably have been, oh, shoot, sorry about that. Let me just, dang. All right, ladies and gentlemen, I'm sorry, I apologize. I am trying to bring up the chat room and I'm not succeeding for reasons I do not understand.
Doctor, you might try the Alt tab to see if you can switch to the chat as well.
Alt H, I think. Yeah, that's funny. I'm doing that, but it's not bringing up the chat room. Is anybody
No, Alt and tab. So hold down the Alt and click on the tab key.
on the tap key? What's a tap key?
Tab. Yeah, tab on if you have a Mac.
Oh, tab. Sorry, tab.
Yeah, sorry.
Oh, there you go. Okay. All right. Alt tab. It's not working for me. I don't get it. Okay. This is what I hate about technology, is everything seems to be going smoothly, and then I do the normal way I'm doing it and it's not working.
Then you might have clicked on a chat one time and have canceled it. So you maybe click on a chat one more time so that it come on the top.
Well, that's my problem, Aiden, is I click on it multiple times and it doesn't do anything on the chat, the word chat. So whatever I'm doing it wrong, and I don't have you right in front of me to say, do this. So if anyone wants to, we're getting close to the noon hour, at least on the West Coast. And if anyone would like to interrupt me verbally, go off mute, etc., and bring up anything, and I'm sure that I'll get this figured. Well, I'm not sure of anything, but I'm hoping to get this straightened out and get that chat box up again, which I'm unable to do right at the moment.
Would you like me to read some of the comments?
Yes, please.
Here? So, okay,
Yeah.
so Eddie Taylor said they should at least consult with the one prescribing the med. And Carmen said, I suppose that this has to do with the shared responsibility on the patient, on the PT for the patient.
Yeah. Okay. I somehow I'm able to get it now, Aiden. That's helpful. Thank you.
Okay.
I'll continue on. As different from professional opinion, Janelle says they should at least consult with the one prescribing the med. Absolutely. I was offended. You know, this was a pharmacist that had been filling this woman's prescriptions. By the way, I think I mentioned she was a judge's wife. She wasn't somebody that you would dismiss, regularly. She was actually like a society matron. And you would have expected a pharmacist who had had a relationship with her to call up the doctor's office and say, "Hey, as a courtesy, I want to let you know I'm not going to dispense this, and give you the chance." But that didn't. I had to call him up. So, absolutely right. Um, all right, and then Carmen, you said, I suppose this has to do with the shared responsibility of the patient. Yes, shared responsibility on the patient. For the patient. There should never be a flat denial, Janelle says, to refill a prescription without consulting. Exactly right. Best practice would have you, if you're going to say no to somebody, you really ought to double check with them, right? Because you're leaving this person stranded. But a pharmacist can do that. They can do that. If they don't feel it's safe, if they're um, you know, um, not happy with it, they can do that. Can you read the comments? Oh, yeah, 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 yeah. Okay, I agree. Yeah, yeah, yeah. Yeah, yeah, yeah. And, oh, okay, Janelle. Pharmacists refused to refill my birth control because birth control is against her religion. There was no other pharmacist when she was on duty. I literally had to come back when she was not working to get the prescription filled. So, yeah, there you go. This is a big problem. And what the fault of that pharmacy was that they needed to have a alternative right then. And I'd be inclined to go back to the head pharmacist and say, hey, I get it. Your religious objection, one of your pharmacist's religious objection to prescribing, to dispensing birth control. But come on, you have to have an alternative if you're going to do that. In other words, here we are trading rights and civil rights. And one's overriding the other needs to have a alternative built into it. And so I would definitely question that. It fits in, and I'll maybe throw in this last little bit of philosophy, Tom's personal philosophy about life and professionals, to this discussion, and that is that I think it's part of my job in life, as burdensome as it is to educate people around me on how to behave properly. And this pharmacist comes into play with that. I could have blasted this pharmacist and said, how dare you refuse my patient? Particularly without even calling me, doing the courtesy for her. She's a long established customer of yours in your pharmacy. How dare you have such terrible customer service and not even give me the courtesy of allowing me to explain the situation, etc. But hey, life is short, and I simply wanted to move through this and not embarrass him and have him do the right thing. So I educated him and I said, thank you for your concern. Here's the facts. Here's the story. Is it okay now? There's better ways to, what's that line about catching flies with honey? And so I've tempered my thoughts and remarks over the years somewhat, but I still believe it's my duty to, if somebody is doing something wrong and I can do something to make it right, to help them, educate them. And I try to do it in as face-saving way as possible, depending on my irritation and anger level. And it served me well to do it that way. Pharmacists are in short supply in Sacramento, and what they say goes. Yep, yep, it's true. It's true. Ultimately, they have, they can do that. All right. Ladies and gentlemen, it is 1 minute before the top of the hour. We should take a 1 hour break and resume again at 1 p.m. Pacific time, 4 p.m. Eastern time. And we will finish our course this afternoon. And we're going to talk through decision trees, clinical algorithms, the legal findings behind the precedents, the law precedents of the right to refuse medication, and culture, and interpersonal relations, and also impaired professionals. So there's a lot to keep us busy with this afternoon on different topics. I hope this has been useful for the morning. Charts and chart writing and how things flow and abbreviations, and I look forward to this afternoon. So we'll start again in an hour. Thank you.